Next up, we have Professor Wenzhao Zhong from Guangzhou Lung Institute, Guangzhou, China. It's a little bit of a departure from staging. We'll be talking about neoadjuvant TKI and surgery, but I thought that was important given the recent studies that had come out. I'll just say that I had the opportunity to meet Dr. Zhong in his hometown, who's an amazing host. We got to operate together, and I really believe he is a visionary and one of the leading minds in what's going to happen in this space. So I'm extremely grateful for you making the long trip to be here, and look forward to hearing your insights. Thank you.
Thank you, Professor Johnson Spicer's invitation and introduction. And good morning, dear colleagues. I'm Wenzhao Zhong from the Guangdong Lung Cancer Institute in Guangzhou, China. Today, my topic is the neoadjuvant TKI therapy and surgery. And the primary goal of the perioperative and neoadjuvant treatment is to maximize the resection of both the primary tumor and preserve the lung function and eradicate the minimal residual disease and making the tumor downstaging and also assess in very well drug sensitivity. And neoadjuvant treatment is also a very good model of the translational research. Actually, when we look at the enrolled population of the ADAURA, Neoadora, and the AURORA, it's highly overlapped, especially for the N2 lymph node positive population. And the potentially resectable and part of the unresectable lung cancer need the neoadjuvant treatment. And 60 to 80 of the lung adenocarcinoma patients harbor the driving mutation. And the role of the TKI treatment in the adjuvant setting and the advanced has become the standard of care, while in the neoadjuvant setting is inconclusive and very controversial. And today I will review the recent advanced and neoadjuvant TKI therapy focusing on the EGFR, ALK, ROS1, and the surgical consideration, and we will also discuss the future perspective in the neoadjuvant treatment. And the CTON-1103 emerging study is the first randomized control study, phase 2 in China, initiated in the 2011 to the 2019. Is comparing the neoadjuvant, the first generation of oratinib, 42 days, and then surgery, and then go on with the 1 year adjuvant oratinib, comparing with the gemcitabine cisplatin 2-cycle perioperative treatment. This is a very interesting study, and at that time the primary point is not the MPR, the primary point is ORR. The ORR is boundary improved, but the PCR is 0 in both groups, and the MPR is 9.7% in the oratinib group. And the progression-free survival was improved, but the benefit, I don't know the benefit come from more for the perioperative treatment of adjuvant TKI, and maybe the combined effect of both of the perioperative treatment. But the progression-free survival improvement did not translate into the overall survival benefit. And how to change it to the third generation of TKI? The phase 2 study of the third generation of TKI, 56 days, got also no PCR, and the major pathological response is 15%. And I think the EGFR mutation population is very heterogeneous, and multiple pathways drive tumor cell survival, including the CMET, the YAP, RBM10, and small cell lung cancer transformation. And just now, the mentioned Neoadora study is a global phase 3 randomized control trial study in the EGFR mutant 2 to 3B non-small cell lung cancer, comparing the 3 group of osimertinib chemotherapy, monotherapy of osimertinib, and pemetrexed cisplatin carboplatin chemotherapy. The primary endpoint is the MPR. And the pathological response showed that the MPR rate was significantly higher with the both osimertinib containing regimen. but the adding of chemotherapy did not significantly improve the MPR rate. And even in the PCR, the single agent of osimertinib is higher than the osimertinib chemotherapy group, maybe due to the pathological evaluation and the other deviation. The surgery summary, in each arm, 91% of the patient was continue with the adjuvant treatment for the sponsor supply. And more than 50% of patients with the baseline N2 disease have down staging. The internal EFS analysis is immature, but it looks like that the three group is very close overlap. And the osimertinib chemo group, the hazard ratio is 0.5, maybe better. And I think the 9 weeks of preoperative difference was overlapped by the very long term of the adjuvant treatment. The update EFS might be contribute to the combined effect of the both neoadjuvant treatment and the adjuvant TKI treatment. And now the next question is how can we improve the MPR and PCR rate of the neoadjuvant TKI therapy? The first idea is increasing the duration of the neoadjuvant treatment. Because the new study is with just 6 weeks of osimertinib, the MPR is just 10, and the Neoadjuvant study, the MPR was improved. While the other study important role of the 18 weeks of neoadjuvant TKI treatment. Therefore, the optimal duration of neoadjuvant TKI is underdetermined. The ctDNA could be used to help to guide the duration of neoadjuvant therapy. And how can we improve the MPR PCR rate with the combination therapy with other compound, maybe adding the amine and ADC, and the translational study is also under investigate. Because the biological behavior of ALK is totally different from the EGFR mutation. Now in this article, the Alino study have report the final analysis showing the PCR is 12% and the MPR is 22%. In our center, there also initiated a lowering study using the induction lorlatinib, the third generation in locally advanced, including the potential resectable and unresectable ALK positive non-small cell lung cancer. The induction lorlatinib is the 3 cycle for the 84 days, and then we will have this multidisciplinary discussion for the patient receive the surgery or the radiation. And we also perform an MRD guide, the post-surgery treatment. And the results show that the MPR is very high of 6% and the PCR is 23%. And almost 30% of the patient was discontinued for a while for the adverse event of the hypercorticostomy. And the surgical outcome is satisfied. And just one case was transferred to the open. And the surgical time is 165 minutes. And we also summarize the surgical outcome of different neoadjuvant treatment pattern, including the neoadjuvant TKI therapy in neoadjuvant IO chemo. And from the surgeon's perspective, the surgical difficulty of the neoadjuvant TKI therapy is more difficult than the neoadjuvant IO chemo, maybe due to the different pathological change between the target and IO chemotherapy. Last week, we performed a lung auto transplantation after neoadjuvant the therapy to avoid the pneumonectomy. The patient located in the central tire of the left upper lobe, but after the neoadjuvant therapy got a PR response. But the margin is, after the sleeve resection, the margin is also the positive. Therefore, we determined to perform a lung auto transplantation. And anatomy, the left inferior pulmonary vein to the up superior pulmonary vein and the left aortic Now the patient, 1 week after the surgery, is recovered very well. And as we know that the surgical difficulty is, and the high layer fibrocarcinoma is very superior than the target therapy, larger than the IO chemo, and AOK TKI larger than the EGFR TKI. And in the ROS1 fusion, we also have analysis of the 19 patients and the PCR after the ALK inhibitor. The PCR is 21% and MPR is 47%. Actually, in the EGFR mutation patient, we have established Minerva scores that divide the patient in 3 groups: the TKI prefer, the chemo prefer, and TKI and chemo prefer, based on the RB1, TP53, and MYC, that the EGFR mutation is very heterogeneous and should be received in individualized therapy. And actually, the microenvironment differ between the early and late-stage lung cancer. In the KEYNOTE-671, part of the patient with the EGFR mutation patient got a benefit from the neoadjuvant IO chemo, and the EFS of the IO chemo is better than just the chemo group. And from the multicenter retrospective data of the IO chemo, we found that the MPR and PCR was improved for the IO chemo group. The PCR is about 10%. And then we initiate a perspective phase 2 study exploring the role of the PD-1 inhibitor plus chemotherapy for EGFR mutation patient. Is a Simon's two-stage study design, and the primary endpoint is the MPR. And we found that the MPR is 34% and the PCR 11%, and the baseline clinical factors and clinical efficacy, so that the sensitivity of A5AR is better. And because the TKI therapy induced evolution, that the TN is the TKI naive status and is the immunosuppressed, and PD is the progression disease, is the also immunosuppressed. But the RD residual disease is the immoderate. Therefore, the role of this suggests that using the immunotherapy in the RD stage may got a better result. Therefore, we initiate a new study of sequential TKI and IO chemotherapy in EGFR mutation non-small cell lung cancer. Firstly, the patient with the EGFR mutation 2 to 3B stage received 6 weeks of the third generation of TKI therapy, and then rush out for 2 weeks, and then 3 cycles of the chemo IO. The primary endpoint is the MPR. And the result is very interesting, that the PCR is 70%, and after the TKI therapy, the radiology response have increased 21% to improve the radiology response. And the no PCR in the PD-L1 negative patient, and in the PD-L1 larger than 1%, the PCR is 33%, and no matter in the TKI neoadjuvant treatment phase and the IO chemo phase, the patient will got a tumor shrinkage. And in the EGFR mutation, LA5AR is better, the result is better than the exon 19 deletion. And this is a case with the patient with EGFR mutation and got a PCR result. And we're comparing the MPR rate of different neoadjuvant treatment regimen, including Neoadjuvant TKI monotherapy and IO chemotherapy. And we have also a survival and in the neoadjuvant treatment strategy for potential resectable stage 3 and 2 non-small cell lung cancer, which which do you currently prefer? And the third generation of EGFR TKI therapy and the targeted therapy combined with chemo and the personalized treatment strategy based on the PD-L1 expression is the three most vote. And then we have a randomized control trial to comparing the Neoadjuvant model and the sequential TKI IO chemo model. And in the other rare mutation, have the heterogeneity response of the ICI among patients with rare mutation. The PD-L1 expression is different and the microenvironment is different. And now this lists the ongoing trial of preoperative treatment for non-small cell lung cancer with the rare mutation, and especially for the KRAS mutation patient, single agent of the TKI treatment and TKI IO treatment and so on. Therefore, I think that in the resectable non-small cell lung cancer, for early stage, we will favor the adjuvant therapy. And for the more advanced stage, maybe will favor the neoadjuvant treatment. In the wild type, the IO chemo is the standard of care, but in the EGFR mutation, we need the precise therapy based on the PD-L1 expression with the TKI chemo or the IO chemo. And the fusion, including the ALK, ROS1, and RET, I think the TKI treatment is the preferred group, but need further study. But in the KRAS, BRAF, HER2, and MET, it may be the combination of IO chemo and TKI inhibitor. We need further study. And our study showed that the genomic correlation analysis showed that the L858R and RB1, RBM10 mutation might inform personalized treatment strategy based on the IO chemo in the population. And the single cell analysis showed that the TCR expression of CCRA, Treg, and high CXCL13 TX may be a defined subtype of EGFR mutation non-small cell lung cancer may be resistant to the IO chemo. And the role of MRD in the neoadjuvant treatment may be differentiate the people benefit from the TKI or the IO chemo. And what's the definition of R0 resection? I think the real R0 resection is the R0 versus the tumor-free, but if the R0 resection and molecular residual disease is positive, it's not a real R0 resection. And in summary, the neoadjuvant observability could be considered an option. While yield limited MPR and PCR response, the long-term benefit of adjuvant therapy outweighs the 9 weeks of neoadjuvant treatment. The EGFR mutation population is a highly heterogeneous group, and individualized biomarker guide treatment pattern and a novel agent should be considered. For other rare mutation, preoperative TKI may be optional but require further investigation. Thank you for your attention.
Thank you, Professor Zhong. I don't know if you guys realize it, but you just saw the next 10 years of data presented already. If any of you have the opportunity well, first I'll take the opportunity to talk to Dr. Zhong. He knows an incredible amount. It's unbelievable what's going on over there. If anybody has the opportunity to go to China to see what's going on, it is next level. In a 2-hour tumor board, we saw all the candidates for these trials, 30 or 40 of them. It is unbelievable. So take the opportunity to chat with him. There's a lot to learn.